Good afternoon, everybody. My name is Andreas Rick. I will be moderating this session together with my colleague Marco Barbanti from Catania in Italy. Today we will see a live case from Essen in Germany. I will just introduce the concept. So the objectives for today is to understand the importance and challenges of coronary re-access after TAVI and learn how valve design might impact coronary access and allows future treatment options for patients after TAVI. We will discuss solutions and techniques to preserve coronary access, and we will hopefully have an interactive discussion with the audience. We will also describe the Acurate Neo 2 system in depth. The Acurate Neo 2 is a TAVI system which is manufactured and sold by Boston Scientific. The Neo 2 version was launched in Europe in September 2020. You will see in the picture that the main difference between the original Neo and the enhanced Neo 2 is the enhanced skirt, which goes higher up on the stent. There is also on the delivery system a radio park marker which enhances the positioning of the valve in the native annulus. There is not so much data out yet on the Neo 2 and its performance with regards to PVL. There will, however, be several presentations at EuroPCR, one of them by myself on the results with regards to PVL with the new Neo 2. Just to introduce the potential problem and also how this valve prosthesis looks. It looks a bit different than other prostheses on the market. So the annular portion is quite dense, and this has the skirt on the outside. Here is the so-called upper crown. These three things in the middle are the stent posts, and then higher up are the stabilization arches. You will notice there is quite little metal in this middle portion. And this is also where usually the left coronary sits. You'll see on this picture here where the left and right coronary usually are located when you use this TAVI system. That means that it's usually quite a lot of space to go down with a coronary catheter to either the left or the right coronary. We will in the end discuss a little bit about the study from Dr. Barbanti with the coronary re-access after different TAVI systems. Maybe Marco, you can mention just briefly what you found.
Yes, Andreas, you got a very important point. Actually, the cannulation after transcatheter valve implantation hasn't been perceived as a major issue of this procedure. But now that we are moving towards younger patients, this is going to be an important step in preserving the future and manageable access to the coronaries once the valve is in. We ran a study. Probably we can go through the study at the end of the live case made by Alex and Thomas, and then we can discuss the impact on anatomical features and the stent device design on the coronary access after TAVI. So this will be a terrific presentation, I'm sure, and we will be able to see how this Acurate Neo valve may perform in the setting of coronary access.
Perfect. So I think it's time to go over to our colleagues in Essen who have prepared the case. So we'll switch over to Essen now for an introduction to the patient and to the case. Thank you.
Welcome everybody. My name is Thomas Schmitz and it's a great pleasure for us to welcome you today in our hospital at the Elisabeth Hospital in Essen, Germany. We prepared a valve case for you and we'll show it now live. What means we? To my left side is the first operator, Alex Wolf. On the head we have Dr. Lenk, who is taking care of the patient, and we have our three valve nurses, Alex, Jenny and Iman, who are supporting us during the case. And I would say first, Alex, will you present the case, please?
Yeah, so we go straight into the case presentation. Today we have 30, these are our potential conflict of interest, which we are wanting to show. Our patient is 38 years old, he's a male. He has hypertension and a lipid disorder. Despite his age, he's an active lifestyle, and also there's no psychological impairment. His prior clinical history includes that he had multiple coronary interventions. So he had a stenting in 2003, which was his first one, on a dominant diagonal branch, and then he had the RCA PCI and a complex mini crush technique on the LAD diagonal 1 in 2015. And there it's also like that diagnosed circ occlusion. His actual clinical presentation now this year was that he suffered from dyspnea symptoms, NUA 3, since 5 months. He has no angina or no syncopes for his symptoms, and we diagnosed this severe aortic stenosis. He has a preserved LV function of 59%. With a mean gradient of 46 millimeters of mercury, which calculates an aortic valve area of 0.8 square centimeters. Besides that, he has a flail on the posterior mitral leaflet, but which only translates into a mild to moderate MR. His CT scan prior to the screening for the therapy options for the aortic valve stenosis. You can see here the area of the annulus was calculated with a parameter of 82. So that would translate into Acurate Neo valve size L. He has a little bit eccentric calcification on the non-coronary leaflet. He has a little bit of horizontal axis, and maybe you can see that on the image of the iliac anatomy, that we have quite some tortuosity in the iliac vessels. Here you can see his baseline angiography. So the right coronary artery was, without any findings. The 2 stents were fine. And here you can see the images from the chronic occluded circ, which has some collateral flow. And we can go to the next slide. All up, we had a heart team discussion about that patient. His risk score, where we still use the logistic Euroscore, was calculated at 7.03. So in the end, our heart team discussions, these are the main points which we discussed in our heart team. He has a low surgical risk, but the patient is an octogenarian and favoring TAVI. He has a favorable anatomy for TAVI. He has a circ occlusion, which needs to be maybe reevaluated in case he has symptoms after the TAVI, and that PML flail, which only results in a mild to moderate MR. We will also reevaluate this once the procedure will be done, and we see how the patient goes with this. So the objectives of the live case will be, we show you the step-by-step implantation of the Acurate Neo 2. We did use, and we did this prior to the live, the Sentinel cerebral protection system, which we placed. And there's the idea of the whole choose of the valve is that we preserve the LCA access for possible LCX CTO. The procedural strategy, we have a single femoral access, we have a secondary radial access, we do a pre-dilatation, in this case with a 22 millimeter true balloon. We will do the step-by-step implantation of the valve, and we will have a suture-based closure, which we also prepared. So the tools and techniques, we did already perform the ultrasound-guided puncture. We do pacing over the wire for the pre-dilatation and maybe for the post-dilatation. We will see that later on in the case. And we will see how we address the horizontal anatomy with the Acurate Neo 2. Thomas, would you like to say something about our procedural setup?
Okay, thank you. So maybe we can show you what we did until now. On the left
just
side,
put one question, sorry.
Yes,
sure.
How is the coronary height? I didn't see that in your pictures. They were kind of small. How high up are the coronaries?
I skipped it. I wrote it down. It was 16 for the LCA and 24 for the RCA.
Okay, so actually no problem. Great, thank you.
Yes.
Yeah. And Alex, what about the sinus of valva? The diameters is not here.
They were good. The whole length from commissure to sinus, they were more than 30 to 31 millimeters. That was quite favorable. Yeah.
Okay.
So we were back to our procedural setup.
So what we did is a puncture of the left radial with a 6 French sheath, and over this a Judkins right, where we did the angio. I hope you can see it, of the right iliac and femoral vessel. You see the kinking, a little bit of calcification, so that we decided to use a stiff wire for positioning of the sheath. Then we did ultrasound guided puncture on the right side. Maybe we can show the ultrasound picture also.
This is how we punctured it. We use a short access.
Yeah. Here it is very important to find the area where we don't have any anterior calcification. And then we did the puncture. We used 2 ProGlide systems and have now a 9 French sheaths in place. And on the right radial, we placed also 6 French sheaths, and over the 6 French sheaths, we used the Clarity device. Maybe Alex, you can show what we did.
Yeah, it was a little bit, if you can see on the angio pictures right now, we had a little bit of a problem placing the wire because the wire always took a turn back into the lower arm. So we had to do quite some maneuvers to maneuver this up. And here you can see the Clarity device moving through the axillary artery. And we're coming in place where we place the proximal and the distal filter. This is the angio prior to the placement of the device. Honestly, this is just to give us a little bit of orientation. The main feature for the Sentinel device for us is the screening on the CT scan for the anatomic feasibility. That's very important that you look at the diameters of the truncus brachiocephalicus and the left carotid artery. And maybe we can show the placement of the distal filter as well. And here's where the distal filter is placed. And yeah, so maybe you guys can comment a little bit on the clinical setup of the case, and we will start working. We will introduce a Landerquist wire in order to put in the large bone sheath, the eye sleeve.
I think it's a good modern setup with only 1 femoral puncture, and using the left radial for the pigtails. I think it's a good contemporary setup, which should allow for low complication rates.
So Alex, Thomas, do you use a Sentinel in every single case?
No, we don't use it in every single case. We do some pre-selection cases where we decide to place a Sentinel. It has also some. We don't really have reimbursement in Germany for using the device extra, so we have to limit ourselves for economic reasons for that. I don't know how it is in Catania.
No, definitely. It's a quite expensive device, but I think it might have some role in patients. So far, we don't know which patients may benefit more from this device. It's definitely something that it should be investigated more, because the evidence are not so striking in using it, but definitely there is a important rationale for using it, in particular when you have a severe calcified valves. Yep. So this is an important question. Go ahead.
Yeah, this is the placement of the large bone sheath over the kinked anatomy that worked kind of very smoothly over the Landerquist wire. Yeah, and I think you're right in the setting of we don't really know which patient really benefits in the sense of freedom of clinical events. Yeah, so we know that the Sentinel system they do lower the MRI lesions, this is for sure. And so we will have to see what the future brings. I think there's 2 randomized trials, one in Great Britain from the UK registry on the way. And, we probably have some more clarity which patient really benefits from using a cerebral protection system.
And Alex, regarding the access, it's nice demonstration, because we saw that vessel was extremely tortuous, was highly tortuous. There was some kind of calcification. You used a Landerquist wire. Is it your default wire for a tortuous vessel, or you just using this case?
Yeah, no, it's not a default. It really depends on the anatomy. In my opinion, in this anatomy with this tortuosity, and using the large bone sheath, is better to use like a stiff wire, like the Landerquist wire, to give you most of support and stretch the anatomy,
Can I ask you a question on the pacing strategy? You're not placing a dedicated right ventricular temporary pacing lead, is it?
Yeah. Yeah, we do also select the patients where we do over the wire pacing, and where we decide for doing permanently lead. So in case you have already like some kind of issues prior, so you have a right bundle branch block or something, we're not so reluctant to use over wire the pacing, and we pace a RV via lead. And you know, in this case, there were he had a PQ interval of I think 180 milliseconds, and he had an incomplete right bundle branch block, and we're using the Acurate Neo 2 valve, so we feel actually kind of safe to use that kind of setup.
Yeah, that seems very good.
So after placing our arm plugs left one, we are now using a Terumo wire with a straight tip.
Okay, so while you're advancing and you're trying to cross the valve, I just want to a little bit step back on the valve choice and just trying to focus on the topic of this live case, which is the coronary presentation. And the question for you is how the extent of coronary artery disease is influencing now your device choice.
So I think this is very important. So when you already have stents in your coronary arteries, and you may need to go in the future again for stenting or restenting or something like this, I think then it's very important to have an easy access to the coronary arteries. And this is one of the topics for us when we choose the valve. Okay, geht raus.
Yes. Maybe it's time to ask the poll question. There is one poll question for the audience. So maybe we can pull it up on the screen and just let the audience vote. So the question will be, how many of the current patients receiving TAVI would be needing a coronary intervention in the future, with 4 different options, 0 to 10%, 10 to 20%, 20 to 30%, or more than 30%. I think it's a good question. I don't know if there is any good scientific data out there showing how many coronary re-interventions are done after TAVI.
Yeah.
And we will come back with the poll results in a couple of minutes to the audience.
20%, no?
Yes, Alex, this is an important question, and probably it's very important to assess that it's not just the problem, in my view, is not some elective procedures to the coronaries, but is the clinical presentation of acute coronary syndrome. We are starting seeing patients presenting with ACS in STEMI and in centers who have no experience in TAVI procedures. So this is gonna be an important issue. So having a valve that can provide a manageable access to the coronaries is gonna be key to the future.
Yeah, I agree. It will be more and more prevalent, and since the TAVI technology is spreading to younger and younger ages, people will use their TAVI valves for more and more years, and therefore high likelihood that they will come in somewhere in also a smaller hospital with a coronary syndrome.
Yeah, so fine.
So now Alex and Thomas, they are trying to put the wire in. This is probably, it looks a basic step of the procedure, but probably is one of the most important steps of the procedures, because particularly beginning of the TAVI experience, it was one of the steps where we messed up the procedure very frequently, which is a proper and a safe way to place the wire in. Alex, what type of wire, stiff wire you place? Do you have pre-shaped?
Yeah.
Maybe we can show the wire.
It looks like a Safari.
Yes, exactly.
Exactly.
I would say in 99% of our cases we are now using the pre-shaped Safari wire. You know, we have this in different sizes, but I would say really 99% we are using this one.
Yeah. And we use a Safari L wire, the Safari small wire for most of the cases.
So we are now doing the measurement of the gradient, and the gradient is around 80.
We have a lot of extra beats, yeah.
But it's around 80, I think.
Yeah.
So correct diagnosis.
Yeah.
Good.
Yeah. You can see also the shape of the pigtail. You know, it wasn't that easy to cross the valve. So I hope we can get a good position of the wire with the shape of the loop facing up. And other than that, we might have to pre-dill and then maybe go in with a pigtail again if we have a... But that looks pretty nice.
I think it's fine.
That looks nice, yes.
Ebene.
Yeah, so also the fact that you don't need to put a dedicated right ventricular pacing lead in most patients when they use this valve system also contributes to safety, because that's one of the major reasons for tamponade during a case. So that's also increasing safety.
Yeah. It depends on, like, we were in the end very careful and using always balloon tip right ventricular leads. And that is the default what we have as a safety measure if we have to pace lead.
Yes.
28 Caudal 5. Also vielleicht machen wir 18 Caudal 5 mal und dann müssen wir gucken, wie wir stehen. So now we have to find a working view. And so with horizontal axis, sometimes the follow the right coronary cusp doesn't really apply that much. So we hope that the CT gives us a good guidance. Yeah, I think it's pretty reasonable for the placement of the valve.
Looks almost spot on.
Yeah.
This is a quite horizontal.
And so, yeah, quite a horizontal aorta, but we will see after with the Acurate Neo we have quite some advantages of that system in placing, addressing the horizontal anatomy.
Mm-hmm. So the next step would now be the balloon valvuloplasty. We decided to use a 22 true dilatation balloon.
So it's a non-compliant balloon which we're using.
And just to reiterate, the calculated diameter of the annulus is about 26, isn't it?
Yeah, it's about 26. So if we have, we can't use that for post-dilatation. We had a minimal diameter of 23, so so we decided to use the 22 and just see how this balloon will open that anatomy. And so we will test now the pacing. So we do a pacing test with 120. Iman, if you
guys, can you show us how to perform a pacing through the wire? How was this?
Maybe just show with the camera how it's connected to the wire.
Can you see? Yeah. Can you show the wire? You see one part of the pacemaker.
Mach noch mal aus, bitte, ganz kurz, weil der Druck runtergeht.
At the wire, and the other one, the other part of the pacemaker in the groin. Just using a normal needle. You can see it?
Yes.
Yeah.
Okay.
Okay,
yes.
it's just a standard needle which you put through, and then we have we do go on maximum output. So that'll be 17 milliamperes, and so we'll start now at 120, and you will see from the ECG that due to that high output which we're using, that you have these big spikes on the ECG. Important is that you don't look only at the spikes, but also of the effective pressure reduction. Okay. So we're going to 180. We have a pressure reduction now. We will open the balloon. Balloon is fine. Balloon down. Pacing off. And then we will see if the patient has his own heartbeat back. So that looks fine. And
very stable.
Very good.
Yeah. And we like the true balloon for two reasons. First of all, it's a good balloon with it's a non-compliant balloon. The second is the inflating and deflating is very fast, so you can really shorten the time where you have a pressure reduction.
It's also very important that the size the balloon of you decided, because you mentioned one important point, that you undersized the minimum diameter of the valve. It was a very quite eccentric. And so I think I found absolutely safe to use an undersized balloon compared to the minimum diameter of the valve. This is important.
Yeah.
But it's, I think, a matter of debate. That's not the point of today's session, but we usually use one-to-one sizing here for pre and post-dill.
Yeah.
Seems also to work. So but maybe not so important
I
here.
I believe you can... you probably have a higher post-dilatation rate if you do that aggressive pre-dilatation, huh?
Probably, yes.
Yeah.
Remains to be proven, though.
One-to-one, there may be some issues in the artery regurgitation, and then you are forced to implant the valve in a very fast way in case of severe AS, but I think, both are absolutely good approach. It depends whether you want to be more conservative and safe rather than to avoid post-dilatation.
Yeah.
Maybe a couple of, maybe we can introduce the delivery catheter,
Yes.
just for the audience which maybe does not know the device yet. So we have like a introducer, which you have to put in the sheath. Like once the valve is in, you can place this and park it here at the handle. And maybe Thomas, you can explain the two opening mechanisms on the delivery catheter.
Yes, we have these two knobs. Maybe you can see it. First, we are turning knob 1, and the crown is opening to stabilize the valve in position. And then the last part is by turning knob 2, we are finally positioning the whole valve. So first 1 and then 2, but we will show it now, I think, live.
Yeah.
And you can see it a little bit better. So first we will cross the arch
Maybe we can
and to
show
see that we don't have interference with the protection device.
So that works very easy. And now we're just gonna come across the arch. Ein bisschen ziehen, ja,
I
super.
will pull a little bit at the wire to overcome this horizontal positioning.
I re-advance the picture so that we make sure that we're most on the lowest part. There's still some movement, so I'm probably gonna do a little bit of a fast pacing. So maybe we could turn on the pacer on maybe a beat of 100. So we have a little bit more stable position. The whole case is done in analgo sedation. So now we have a little bit more stability in the system. And maybe we can take a root shot here. Einmal bitte darstellen. Yeah, we're still a little bit off. So I'll try to advance the picture to the lowest point.
For the audience, this is one of the most interesting evolution of the new device. So you have a marker into delivery system that indicates what level you're gonna implant the valve.
Yes,
So-
it's a 7mm marker, which is
Okay.
the recommended depth, more or less, for implantation. So,
Okay.
yes.
Einmal bitte nochmal darstellen. So now we're, in my opinion, on a good position.
Looks very good.
And so we start to turn the knot number 1. This is always done in a very slow way. And stop here at that point. Because of that horizontal anatomy, maybe we have to keep it a little bit on push. So we will take a root shot now to confirm the position. The upper crown of the device towards the aorta is opened. Maybe we can give it a slight push inside. I'll give it a bit of a push.
Not more.
Yeah, and Thomas, you can continue the number 1.
So important to understand that the annular part is opening last here. That's the number 2 knob.
Okay.
And
So
what the
now
operators do here is
we
just
do
what's recommended in the IFU to
some-
have some push on the system.
Yeah,
And you
einmal
can
zeigen.
see nicely with the device lying on the outer curve of the aorta, which is a very nice position.
Fine.
Yeah, right.
Okay, and now knob 2, fast. Okay.
I made a little jump.
And you see, so yeah, and you
Face
saw
out.
what it's also recommended that the nose cone went forward during release. So that means there was some push on the system, which is intended. All very good so far.
So we
So
bring
now
in the safari wire in order to retrieve that a bit of a bulky system in a safe fashion. Okay. And the pressure already recovered.
So ECG is fine, pressure is fine.
You can also see the valve stent nicely open, so it seems like it opened up well.
Yeah.
How fast was the pacing, Alex?
100. I just did it to suppress some extra beats in order to have a little bit more stable implant situation. Thomas already assembled the delivery catheter so we can safely retrieve it. And then we're just going to take an angio and have a look at our results in terms of AR and height of the implant.
Okay.
The valve was incredibly higher, and this is for the audience. This was a very tough anatomy for TAVI. and quite a tough anatomy because the valve was very horizontal. You see the wire was really almost 90 degrees valve, and the valve was really, it looks perfect.
And I think we have still a little bit of central aortic regurgitation due to the wire, and maybe a trace on the left, but it's really more or less nothing. Huh?
Yeah, the valve is
for me it's
very
okay.
limited.
Yeah.
Deep into the
So we do
vein.
have some. Yeah, we will measure we will introduce a pigtail catheter in order to take out the stiff wire, and then maybe we'll see if we get any changes, because it looks there's a central component of the regurgitation, and as
what do you think?
Yeah, what do you think about the result?
There is a little leak, but it's always hard to tell is it the wire or not. So one recommended way to check is actually like what you planned is to go in with a pigtail. Then you can also take advantage of the pigtail and measure the LVDP and see if that's high or not. I think that's a very good step.
Yeah.
Maybe we should comment on the antegrade gradient of this valve system. Is there a need to check the Vmax or mean gradient through this device usually? And what the operators say? My opinion is that it's very rare to have a high gradient in the valve from this system if it looks expanded.
Right.
So that's rarely a problem, if ever.
Yeah. Haben wir schon gemacht.
So I have Alex Thomas, while you are preparing from hemodynamics check, I have a few questions for you regarding the view projection you use to implant the valve. We know that more recently is going to be almost routine to use. So you use a 3-cusp view to implant the valve, which is the default view. Now we have this cusp overlap view that allows quite the lack of foreshortening of LVOT. So do you use this projection, or do you still find this reproducible, safe?
Yeah, so you mean the right cusp overlay technique? Yeah, I think for some devices it's useful. I don't really find it particularly useful for the Acurate system, in my opinion. I think it's kind of difficult, and it might give you some bias on the position. Here it's more important that you have a co-planar view, and that when your valve opens, that you have kind of a very central way of looking at the valve. No?
Okay.
Yeah, I would also agree with Alex, because one point here is that you should have it lying in the outer curve, and that you see better in the cusp overlap, or not cusp overlap, in the 3-cusp view. Sorry.
Now you got an important point, because it's very important to see how much tension you're putting on this device, particularly in these very complex anatomies. So in case you want to use some that start using the cusp overlap view, it's very important to check in LAO view to see how much tension you're putting on the catheter. And LAO view, I think, should be the final, so the 3-cusp view, should be the final position before release the valve with the second knob.
I agree.
Okay, now you can see the hemodynamics.
Yeah, maybe you want to comment on the hemodynamics, Andreas and Marco?
No, mostly not.
Well, no gradient, that's for sure.
Gradient? I think that the systolic pressure looks fine. The LVDP is quite low. So I think according to there are some extra beats, but according to this hemodynamic, I wouldn't say that the leak is clinically significant and hemodynamically significant.
Yeah.
Probably.
Yeah.
If you want to do another.
Yeah. We will perform an angio on RAO 30, just to maybe reevaluate the leak, and we can leave it, or maybe if we need some post-dilatation, that we will see now. Just because we have a little bit less foreshortening of the LVOT, so maybe we can see what the leak is. I will keep, although it makes a little bit bias, I will keep the pigtail in the LV for this, just in case re-accessing this might give you some problems. Yeah.
So there is some parallax and there's a projection, but I think, the leak is, it doesn't look like quite significant. So it means that most of the ER we had, it was due to the wire. The pigtail is softer, so it doesn't.
Is it possible to look at it on echo directly and see if it looks central or not? If you look in short axis on echo? It would be.
So we have to.
I guess in any rate, it's not a. I would say it's a grade 1 leak, which is acceptable, and that
Robert,
should
soll mal
be
reinkommen, mal
left.
kurz Echo machen.
Yes.
Well, you have a very tiny leak on our angiogram. You have a quite satisfying hemodynamic.
I tell you the truth is like if you can go back maybe one angio, the angio prior angio, is I think we had it was a challenging case in terms of the horizontal anatomy, and despite the push I had on the valve, while it opened, it went a little bit higher than I intended to have it, and so this case you really have to consider twice before you post-dilate it, because if you have some more foreshortening of the stent cage, you can have also a pop-up. So I want to be really 100% sure that we have a significant leak before I would address this with a post-dilatation.
No,
I would agree. I think it's very infrequent that it jumps, but it's also one of the reasons for the grade 1 leak here is probably that it's slightly high, the valve. That's maybe one of the reasons, and then that also means that the post-dilatation will not help for that.
And Alex Thomas, getting back to the focus of this live, do you think that high implantation, this is a very good implantation in terms of reduction of the risk of conduction disturbances. Do you think that a higher implantation may make future coronary access more challenging also with this valve, or you don't anticipate any issues?
Yeah, well, in my opinion, it depends on two factors. It depends on, first of all, where the commissary lies. Yeah. Exactly, in terms of the LCA, this is something which is quite important. And the second thing is it depends on the width of the sinus of Valsalva. How you can re-engage these coronaries after that procedure. Yeah. Mm-hmm. Okay. Can you see that?
On a picture yeah. Okay, fine. Size of the leak so far seems to be really minor.
Yeah, it's a minor leak, even in terms of echocardiography, So
and the pigtail is still in place.
Yeah.
So I think.
Yeah, I think my decision would be fine. In this case, I would leave it.
Yes, I agree. There was a question from the audience about commercial alignment. Now, I know for this case, there was no intentional rotation of the device or so. Okay. We can just say that from the final aortogram, which was in the cusp overlap view, we saw a more or less equal distance between the 3 stent posts. So that means this device, in this case, was actually quite well aligned commercially. But there is also a special technique which will come out from Boston Scientific for achieving a perfect commercial alignment in all patients from the CT calculated angles. And there will be a recorded case from our institution, which will be up on EuroPCR on that topic in just a couple of weeks now.
Now, this is, Andres, is very important because so far we have to underline that the current device is not designed to obtain an intentional commissural alignment. So this is very important. But there are some techniques in order to obtain a better commissural alignment. For example, to put the pin on at 12 o'clock and at 6 o'clock.
6 o'clock, yes.
Other than, because usually we implant, as they showed very nicely, at 12 o'clock, but probably looks like orienting the pin at 6 o'clock, you might obtain a better commissural alignment. But this is still ongoing, and then we definitely need more data.
What's good with this device is just by chance probably, but there are lots of markers to look at when you want to see how it's aligned. So the 3 stent posts are very clear in the picture, for example, if you compare to the other TAVI devices. So it's actually quite easy to determine how your alignment is during implantation. That might be an important factor.
So now Alex and Thomas, they are retrieving the Sentinel device. So and I would agree with them not to post-dilate, and I think we're definitely happy with the final result. So this is time to remove the Sentinel device.
Yes.
So Andreas, what about you, and what about the valve? Which is your valve choice? How did it change in the last couple of years regarding your decision what kind of valve you implant? So because I remember a few years ago, we never thought about coronary access, to be honest, a few years ago.
Yes.
It's going to be probably one of the most hot topic today in TAVI field, but do you think it's really justified from evidence, from clinical need, or is just something not really?
I think up until now, I think most European centers, they implant TAVI valves from the age of 75 or around that, according to the current EC guidelines. But I think that will change in the next year or two. That will go down to lower ages. And so in these patients, it's higher likelihood to have a coronary event in the future, just because they will use their valve for more years. So I think this topic will be more and more important with the coronary access. Mm-hmm. So some people argue that this valve, the Acurate, has quite high leaflets, so therefore it's difficult. But I think that's not the factor here. So what we see usually when we use this valve is there is very little metal to impede or to stop the engagement of the coronaries when you want to re-engage coronaries afterwards. And that's, I think you will mention it later also during this session, the data that you have collected on the re-access of coronaries after TAVI.
Another question for you and also for Alex and Thomas. Just now that we are closing the access. So one of the questions regarding the eye sleeve, which is a quite nice sheet, but the problem is that probably it's a little bit soft when you have a very tortuous anatomy. I think Alex and Thomas, they did a very nice and important presentation of how this sheet might perform also in this anatomical scenario. But have you had any issues in this case or not? In cases like that or not?
Yeah, on our center we introduced this sheath over ultra stiff wire, so that's slightly softer than the Landequist, but still quite stiff. And we use it even in very tortuous arteries. Sometimes it looks a bit battled when you take it out, but it's even if it's a little bit kinked, you can, in our experience, always cross with the device. Since the plastic is kind of soft in it. So I don't remember any case where we couldn't use it and had to exchange for a stiffer sheath. Mm-hmm. And we also use it for subclavian or transaxillary access as well.
Yeah.
So you used Pro glides, right?
Yeah, we use 2 Pro glides standard fashion. Yeah, 10 and 2 o'clock. Mm-hmm. It's a default closure device. We do have cases where we use the Manta system.
Mm-hmm.
Kann man aussehen, oder? Yeah.
Okay. Looks very encouraging. Great.
Yeah. Sometimes we are doing a testing with a 6 French sheath and maybe using another Angio-sealed system. When this 6 French sheath goes smoothly in. Yeah. But in this case, it looks really good. So I think we don't need maybe a little bit of. Ich drücke noch mal. A little bit of pressure.
How does the ECG look? Is it still narrow complex?
Yeah. Can you show the ECG? Yeah.
Nice.
Yeah, the valve was quite nicely high, so we do not anticipate any conduction disturbances here. It's fine.
Great. So I think everything went smoothly. It was a nice implantation, good result, no complications at all. Very calm, nice atmosphere. So really no rush to implant the valve.
Alex, Thomas, do you have any final remarks on this case, or just let do the shot?
We just want to do the final angio of the right femoral.
good.
Perfect.
Oh, it looks good.
Very good.
So did we have any catches? Maybe we can show you the result of the protection device.
Yep. Why not?
So we did some debris. I don't know if you can see it. Maybe I can.
It's a bit
So
hard
there
to
is
see.
a little
but
bit of. It's too nah? Okay.
Yeah, it looks like a thrombus, yes.
what we call
Oops.
small fish, but still fish.
Small fish, yes.
Well, Alex, Thomas,
Yeah.
this was really terrific presentation. You did a nice job. This was really, it looked like it was an easy case, but this was really not an easy case. This horizontal aorta was, I remember at the beginning, particularly with the self-expanding valves, it were very, very complex procedure to make. So with the Acurate, I think, in case you want to go with a self-expanding device, to be honest, I think the Acurate Neo should be considered, at least in my experience, but probably now I'm listening about this experience of the referring valve, because it's really very stable. You made a very good presentation, a very good example how can be also useful in this case to use a pacing. Not a very fast pacing, but a pacing just to make more stability on all the system. We obtain a quite very good position, quite high, no conduction disturbances. So this is important. It was a very tough case also in terms of iliofemoral access, very tortuous. But we realized that the EI sleeve performed quite well. Also the closure with two devices, two probe lights were absolutely efficient and efficient. So I think you made a really very nice job. Do you have any comments? You want to make any comments on this case? So we have a few minutes more to discuss.
Yeah, Marco, you basically summed it up very, very well, in terms of the complexity of that case. I think, it's very important. Maybe one final comment is if you screen for the TAVI patients, that you really do find out and a patient-tailored strategy for the patient, in terms of access, in terms of conduction disturbances. And this is something we have to take much more into consideration, also in terms of having the possibility to have a coronary re-access for that patient, which is a little bit the topic of our session, and that you take all these different kind of things together and then you adapt your material and your valve selection to it.
Yeah, and this I take the advantage of to launch the second poll for this live case, and this regards the main factors limiting coronary access post TAVI. So we might have this feedback from the audience. So the first option is the anatomical factors, for example, the coronary age, or the diameters, procedural factors such as the implant 8 and the valve orientation, what type of THV you selected, so different TAVI design, or also, and this is also important, the training, because we know that we are going to have some experiments to obtain a commissural alignment in the next future. So how training in this will be important. So just pull this question for the audience and then make the votes. So this is our second, then we can see the results from this afterwards. In terms of final comments, I think you sum it up quite nicely. We still have 9 minutes to close. And I think also just getting back to the main focus of the session. Yes, the coronary access is very important, and as I said before, and this is very important, particularly in centers in which there is no experience in TAVI. So it's gonna be very, very frequent to see patients stemming with TAVI device and a STEMI. And we have today a bunch of literature showing that the failure of coronary access may be an issue, and this is important. I don't know if you guys had experienced cases like that of acute coronary syndrome of a STEMI patients with a TAVI valve inside, where you had some trouble in getting in, and if you have some tips and tricks to help us in trying to engage the coronaries. This is a question for you guys, Alex and Thomas.
Yeah, I just remember, I'm lucky, I just remember one case with a STEMI after valve implantation, and it was an old core valve device, and this was really difficult. So what we learned is to use not the standard guiding catheter which we are using normal, like an EBU 3.75. So in this case, we are choosing a Judkins left, one size smaller, and we try to engage the cage of the valve with our 0.35 wire. And then after this, we are going forward with the guiding catheter. But it's not very easy, to be honest. So we are very happy if we have a valve where we don't have so many difficulties with this.
I think this is also an important topic, not only for high volume centers which perform TAVIs, but you have a lot of centers which offer 24/7 PCI, and they get the acute coronary syndromes, and they more and more frequently get the patients which have valves in place. Yeah, and so I think it's very important that in the future that you will have for these kind of valves also a proper training for PCI operators. I think that will be very important if you see how TAVI is advancing in the next 5-10 years. You will need to have some tips and tricks for these colleagues, which maybe don't do TAVI, but which will see the acute coronary syndromes after TAVI.
Andreas, can you recall some crazy case?
Yes, I can. So there are a few cases. I don't remember any case with the Acurate actually where I had some big problem, but I remember also with old core valves where you have more of a dense stent in front of the coronary, and sometimes also with the Edwards. If you have a sinus of Valsalva that's not very high, then it might be that it's going all the way up there, and then you might have some problem coming through too. There are, of course, tricks you can try, different catheters, which usually work, but still, if you're pressed for time in an acute case, that's not so pleasant.
Do you guys think that the upper crown of the Acurate may also contribute in preserving the coronary access? I don't know. Do you think it's just something hypothetical that the upper crown might provide to have a more free space by pulling down the leaflets, or is just something that is not really true?
Not completely sure if it's pulling down the leaflets, but it's also preventing the stent to go all the way out in the sinus of Valsalva, actually laterally. So since it has a depth of a few millimeters, that might be useful. I'm not sure.
So I don't know if you have the results from our polls. If we can present it now, or let's see, because I don't know if it's...
Maybe we should ask one. Yeah, we have the result. Great. So the first question, which was in the beginning, how many of your current patients are at risk needing a coronary intervention in the future? Where the most frequent answer was the highest number, more than 30%, 44% of the participants voted for that one, which seems reasonable if you think about that people will have these valves in and use them for more than 10 years. Seems likely. And for your patient that you have, it seems to be a high probability that he will come back for a coronary procedure for sure.
So let's see what about the second poll. So the factors that can limit coronary access post-TAVI. So once again, procedural factors like implant height and valve orientation, THV selected, so different TAVI design, anatomical factors, and training. So let's see. So it looks like that the first one, so the THV, no, they are moving now.
Seems to be really a live update here on the results.
Yeah. We are like result pooling here.
Okay, two options seem to be close to each other at least.
Yeah, it looks like the anatomical factors and the type of valve implanted, they, according to our audience, looks like the most important factors. And it definitely makes sense. It's updating now, and the training is going to be the last. I think training also might play a role in the future. Once the techniques for valve implantation and for commissural alignment will be much more, standardized. So I think it will be also important training, not just in implanting the valve, but also how to select patients. So I think this might play a role in the future. Yes.
Marco, maybe it's time for you to discuss the re-access results that you have, and maybe mention them briefly.
Yeah, briefly, just we can discuss. I think we mentioned most of the issues. I just want to point out the few results of re-access study, which was the first prospective single-center registry that specifically investigated the issue of coronary cannulation after TAVI. So we included in this single center 300 consecutive patients undergoing TAVI with any THV designs. Basically, we implanted Acurate Neo 1, Sapien 3, and Sapien Ultra, and Evolut R, Evolut Pro. The primary endpoint was indeed the rate of coronary osteocannulation failure after TAVI. And it was interesting to see that a successful cannulation rate was up to 7.7%. But more importantly, over 23 cases of unsuccessful coronary cannulation, 22 was observed with Evolut with just one single case of coronary access unsuccessful cannulation with Sapien, and no cases of unsuccessful cannulation with Sapien with Acurate Neo. The main outcomes was basically summarize what we just saw today and discussed today, that a combination of valve implanted, in particular the use of Evolut valve, the deep of implantation, and the ratio between the transcatheter aortic valve size and the sinusal valsalva, the combination of these three factors predictor in a significant way the impossibility to cannulate effectively the coronary access. So this means that our patient selection should be really focused not just in anatomical factors, but also what kind of valve we're going to implant and what size and how deep the valve we should implant. So it's very important to see that a very and a highly tailored approach, as Alex and Thomas showed us today, is very important for our patients' care. So I think we are done with time, and probably we are definitely in time. So we want to thank you, Alex and Thomas. They made an excellent presentation. Everything, the flow was absolutely great. It was a very educative live case. They are very coordinated. It looks like if I have an aortic stenosis, I will be there. And really, this is welcome. A very.
I hope you don't have one yet.
Really made a great presentation. You were very coordinated, very calm. It was a very complex case, and it looks like it was a very easy. And I would like to thank you, my co-chair Andreas Schruck, for helping. We helped each other in making this presentation. I think it was definitely successful, and wish you a good day, and thank you very much to all the attendees for attending.
Thank you. Thank you. If I need coronary re-access, I will go to Essen for sure. Okay, thank you. Bye.
Thank you very much. Goodbye.
Bye-bye.